The next session is on pre-operative planning. Now, I think what we're not trying to do here is to square the debate about gross total or maximal total resection versus subtotal resection, and that probably would be in the controversies section, and we'd never have enough time to solve the problem. But what we are trying to do is to try and remedy the problem that sometimes happens where there's a disconnect between what the surgeon intends to do with his operation and what the oncologist actually needs them to do.
So yes, this is going to be a bit of a whistle-stop tour of what, as a radiation oncologist, I'm looking for from the skull base surgeon. Okay, so this is a quick summary of the points I'm going to run through in this talk. So in terms of imaging, as has already been mentioned, we need both high-quality MR and CT, and it's particularly the bone windows. And that should be reasonably soon before each surgery. I say before each surgery, but if there are a couple of operations in quick succession, a few days apart, then actually, you know, imaging before the first surgery will suffice. But where there is some interval between the surgery, it's really important we have repeat imaging before the next surgery, because there may have been tumour growth in the interim, and we need to capture that. And as Rek has already said, it's really essential that we're able to define the pre-op extent of the tumour, because we need to cover the pre-op extent as well as residual sites of disease during the proton treatment. At least some of the imaging should be thin slice, and that's typically up to about 1.5 mil slice thickness. And that's really essential for accurate tumour localization in our planning system. The thick slices can still be very useful to visualize the tumour in our radiotherapy planning, but we do need the thin slice for more accurate tumour localization. And that reduces uncertainty in the tumour location in our planning system. It means we can delineate much more efficiently, and we can keep the target as small as possible, which spares the normal tissues, the adjacent normal tissues, during the radiotherapy treatment. Importantly, if we don't get high quality imaging before the surgery, there is no way we can recover that information subsequently. No matter how good our radiotherapy planning scans, if they haven't had good preoperative imaging, we cannot recover that information that we need to know, and that will tend to make target volumes larger. So here's an example of a chordoma, and outlined in red is the gross tumour volume, shown in the left on a T1 thin slice 1.5 mil slice thickness scan, nicely accurately delineated, I hope you would agree. On the right hand scan, you see on the same CT slice in our planning system how that appears on the thick slice 3 mil T2 slices, and clearly it looks like we've under contoured the tumour, but that is purely the effect of the slice thickness of that T2 scan. And if we were to increase the contour to cover what we see in the T2 scan, we would be over-treating and increasing toxicity, for example, to brainstem here. Next, just a brief word about the operation note. So as Rek has already mentioned, we really need to know about possible sites of residual, and that's to use in combination with the radiology report to help determine areas that we will try to get particularly high dose into. So the treatment in general is high dose, but if we're aware of sites of residual, we'll make particular efforts to ensure that those receive the maximum dose. We also like to know about breach of dura, and that's particularly true for chordoma, that it can be quite sticky, it can contaminate the surfaces it's been in contact with. So we like to know about sites of dural breach, and they may influence the planning. We also want to know about implanted materials, particularly high density materials, so metalwork, etc., which hopefully is not near the tumour site. But even if it's somewhere near the beam path, it does affect the proton plan, and we need to, in the proton planning system, assign a density to that to ensure accurate proton dosimetry. So I'm going to talk quite a bit about clearance from the critical structures and try to explain why that's important. So we are typically treating to high dose, higher than we treat for other brain tumours at least. So around 74 gray for chordoma is a typical minimum, around 70 gray for chondrosarcoma. And this is above the tolerance of the brainstem and the optic apparatus. But in our planning, the brainstem and the optic apparatus take precedence over the dose to the tumour. So we will compromise the dose to the tumour in order to maintain safety to the brainstem and optics. The one exception to that being that occasionally, I would say uncommonly, we may allow a higher dose to one optic nerve, particularly if the patient agrees to the possibility of visual loss, in order to adequately treat the tumour. The brainstem has a slightly higher tolerance than the optic apparatus, so typically we allow around 63 Gray for the brainstem surface. That is to say that very small volumes of the brainstem may receive more than 63 Gray. Now, that is well below the prescription dose for chordoma and below the dose for chondrosarcoma. So the implication is that if we have tumour, for example, abutting the brainstem or the optics, we cannot get this full prescription dose into it, and the coverage of the gross tumour will be compromised. The optics are even more limiting for us because they have a lower tolerance, so we'll be aiming for a surface dose around 60 Gray and a mean dose lower than that. And these figures may vary slightly between different proton centres, but the basic idea is the same. But because of the optics being smaller and because of the sort of intricate shape, it's even more difficult to get high dose in near the optics. And hence why it's important that we get at least the gross tumour away from those structures. Why does underdosage of just a really small part of tumour matter? Well, we think that the tumour control probability relates to what we call the equivalent uniform dose. And the equivalent uniform dose we can think of as reducing an inhomogeneous radiotherapy dose distribution to an equivalent a dose distribution with an equivalent homogeneous dose. In other words, it would have the same tumour control probability as this inhomogeneous dose distribution. And when we do that, the equivalent uniform dose is actually heavily influenced by the areas of lowest dose to tumour. In other words, if we have a particular dose distribution in which even a small part of the tumour is underdosed, that heavily influences the equivalent uniform dose and the chances of tumour control. And there is evidence from Massachusetts General showing that the target minimum predicts the local control better than the prescribed dose, and the equivalent uniform dose predicts the local control even better. So that's why we are bothered about areas of low dose close to critical structures. I have a few examples. So this is an example of chondrosarcoma, which unfortunately was operated about 4 times at an outside centre before being referred to us. And unfortunately, after those multiple surgeries, although there was good resection of the tumour near the brainstem, a part of the postoperative tumour bed appeared to be tethered to the brainstem at radiotherapy planning. So what we're showing here in blue is our high dose target volume, and in green, an area that we're trying to treat lower dose. And both of these abut the brainstem, which is not unusual actually, that perhaps a tumour doesn't abut, but that because of previous contact, our radiotherapy volumes do abut it. But here, because we have actual tissue right up to the brainstem, it's really important that we do cover that and we get radiotherapy dose right up to that interface to cover as much as possible of that high dose volume. And that we achieved. But you can see here on the 9-month post-proton scan, a small area of radiation changes in the brainstem. Unfortunately, this was asymptomatic, what we call grade 1 radiation necrosis. But this just shows, I guess, the vulnerability of the brainstem to the doses round about the surface doses that we are allowing. This second example is of a large chordoma operated excellently, brilliantly at an outside institution. It was a very large chordoma, actually clear of the optic chiasm, but involving the optic nerves pre-op. And this patient had an excellent near total resection, leaving just a possible 0.4 cc residual 3 millimeters from the right optic nerve. And that's demonstrated here. This was an area of equivocal residual. We've got again in dark blue our high dose target volume, and in green our lower dose target volume. And we had to try to get the maximum possible dose into this volume, which was felt to be not ideal for a second surgery. So that residual was 3 mil from the right optic nerve, but fortunately sort of relatively favourable anatomy. And this shows the dose that we were able to get into that gross residual tumour. And so for chordoma, our prescription dose was 73.8 gray. We managed to get a minimum of around 70 gray, a maximum of nearly 78 gray, and a mean dose of 75 gray. So actually, although it was 3 mil from the optic nerve, we did quite well here. So if we look at the dose distribution at 60 gray, all of this area is covered. At 70 gray, we're no longer trying to cover this low dose target volume, but we still have good coverage of our residual tumour. And at 74 gray, we're starting to lose some coverage of that residual gross tumour. This is a final example of a very tricky case, a chordoma arising within the brainstem in a teenager. We think probably arising from this bony spur that you see on CT, and you also see here on the T2 MRI. So a very large tumour that may look like it was just indenting and compressing the brainstem, but actually at surgery, which was by Mr. Pathmanaban, he described a Swiss cheese appearance of pockets of tumour interspersed with parts of brainstem. And this girl amazingly had a macroscopic complete resection in 2 stages. So the vast majority taken by an expanded endonasal approach, but the second stage, a right retrosigmoid craniotomy. But this is tricky for us for radiotherapy planning, because normally we try to limit our target volumes for chordoma to the surface of the brainstem, but we can't do that here because the tumour was going through the brainstem in a sort of Swiss cheese pattern. So we've delineated an additional target volume here in purple. And this is the area where we think, as best as we can determine, there was tumour interspersed between brainstem surfaces internally within this volume. So we now have 3 volumes. In magenta, we have this low dose target volume that we're trying to give 59.45 gray to. In dark blue, we have the intermediate, try again. We have in dark blue our standard high dose target volume, which is hugging the surface of the brainstem, but we've then generated this additional volume that we can't give the very high dose to because it's internal within the brainstem, but we'll try and give an intermediate dose to. So we tried to give 61.5 gray, whereas the high dose volume, we're aiming for nearly 74 gray. And this shows you what is achievable, which is necessarily some kind of compromise because we can't treat the internal part of the brainstem to very high dose. So this is 95% of our low dose, and the low dose volume is entirely covered. This is just above our low dose target dose, and we've still got good coverage starting to come away in part of this low dose target volume. 63 gray, which is the dose that we can tolerate to the surface of the brainstem, we've got good coverage to the surface of the brainstem, but not the internal. And then at 70 gray, where we're trying to cover the whole of this blue high dose volume, we cannot cover it in its entirety because we have to come away from the brainstem surface at that dose. So I hope that gives some kind of idea of the compromises that have to be made in the radiotherapy planning. Yep. So just to mention, residual gross tumour, what's the importance? There's evidence, for example, from this series from the Swiss Proton Therapy Institute, that the residual gross tumour volume receiving less than 66 gray affects local control. And that's probably particularly likely where it abuts optic apparatus and brainstem. I'm going to skip over metalwork just to say it's unfavourable. And if you're going to put it in, please can we have a discussion about it? And that's just to summarise what I said at the beginning, the things of importance to us. Thank you.